Hello, I'm Jennifer Major. Welcome to today's event that will showcase promising practices to support retention of the healthcare workforce in northern, rural, and remote communities. Please note that this session is being recorded. As I mentioned, I'm Jennifer Major. I'm pleased to be your host today on behalf of Healthcare Excellence Canada. I'd like to acknowledge that I'm calling in from rainy Ottawa today, which is traditional unceded territory of the Algonquin people. I grew up in Corner Brook, Newfoundland on traditional Micmac territory. As I turn it over to my co-host, Randy, to introduce himself, feel free to introduce yourselves in the chat. Randy, over to you.
Thanks, Jennifer, and greetings to everybody from the heart of Treaty 1 territory and the homeland of the Red River Métis. I'm here in Winnipeg, Manitoba, where it's beautifully sunny and hoping it stays that way through the weekend. Have a family wedding this weekend that's going to be partly outdoors. I'm really pleased to be co-hosting this event, representing the Canadian Institute for Health Information. We've got an excellent session planned for you, including time for your questions and discussions after the presentations have been presented. But first, back to Jennifer to help us get set up.
Just a few logistical items before we begin. We're pleased to offer French simultaneous interpretation for this session. So if you'd like to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. Second, share your questions and comments in the chat box as we go along, including any requests for technical support. As for the agenda for today's discussion, we'll start off by sharing some context on the need to support retention of the healthcare workforce in northern, rural, and remote communities. Retention of the workforce is, of course, a challenge in urban communities as well. And the strategies you're going to hear about today may be adaptable to fit urban community context too. Then we're going to have healthcare leaders from 4 sites share information about promising practices that have worked to support retention of their healthcare workforce, the communities in which they live and work. Following all 4 presentations, Randy will facilitate a question and answer, so keep your questions coming through the chat. A note that you can also find the summaries for the practices that we're going to discuss today on the HEC and CIHI websites. We'll pop the link to that into the chat now. So we'll just go to the next slide. Before we move to hear the presentations, just a bit of context on the focus of retention for today's webinar. We know that to address the healthcare workforce situation, we require action in many areas, from recruitment to education, scopes of practice, for example. However, for this, we're going to focus on retention of the current workforce, especially as we know that many healthcare professionals are leaving the workforce or having feelings of stress and burnout. And we're really excited to be shedding light on what's working well. Over to you, Randy.
Thanks, Jennifer. Just a few words about the settings that we're talking about today, because we're trying to focus these, and the examples we've got are all from northern, rural, and remote communities. So as you probably all know, Canada's population has been slowly becoming more urban for decades, but almost 18% of Canadians currently live in rural areas. And many of them live with more health challenges than their urban counterparts. So ensuring equitable access to safe, quality healthcare is critical. But simply offering a scaled down version of what works well in urban areas often does not work well or at all in rural, remote, and northern areas. So recognizing the unique characteristics of each area is key to planning and delivering health services that truly match local needs. There is not just one rural solution. On to the next slide, please, Sheena. So providing those services across this full range of settings means facing a number of unique challenges, including regularly revising service offerings to ensure they're keeping up with the ever-changing needs of the people served. And while HHR challenges in big cities are a real issue these days, most rural providers are facing even larger problems. And remember, they had lower numbers to begin with. As a result, rural health systems are forced to get creative in exploring new ways of leveraging the skills of the staff they have, even if that means doing some things differently today than yesterday. Virtual care options provide an extremely flexible and convenient solution for some issues, but we all know that many health services require physical examination and intervention. So virtual options are great to have, but can't cover the full spectrum. Next slide, please, Sheena. So without further delay, I'm pleased to introduce the first of our 4 speakers for this afternoon. A reminder to share your questions and comments during the presentations in the chat, and we will answer questions at the end of all the presentations. So our first up is my good friend Shannon Guerrero, the Vice President of Clinical Services, Interprofessional Practice, and the Chief Nursing Officer for the Northern Regional Health Authority in Manitoba, to present on their Nursing Practice Council. Shannon, it's over to you.
Thank you very much, Randy, and thank all of you for being here today. Good afternoon. First of all, I'd like to acknowledge that the Northern Regional Health Authority is situated on Treaty 5, 6, and 10 territory, and that Manitoba is located on the traditional ancestral lands of the Anishinabeg, Anishinaabe, Denizulin, Nahuatl, Inuit, Nihawayak nations. We acknowledge that Manitoba is situated on the homeland of the Red River Métis. We respect waters, land, history, language, and cultures of the First Nations, Métis, and Inuit, whose presence enriches Canadian society. We respect and acknowledge that we are all connected through the spirit and intent of treaties and treaty making, and remain committed to working in collaboration and partnership that all encompasses equity, justice, truth, and reconciliation. The term Indigenous means First Nation, Métis, and Inuit inclusively. We acknowledge the unique status of Indigenous peoples in Manitoba and Canada. Next slide, please. So you can see just from the slide that that Northern Manitoba encompasses a large part of the geography of Manitoba. In fact, Northern Manitoba, the Northern Health Region, encompasses 2/3 of Manitoba. However, we have only 1/5 of the population. So basically, geographically, we're very large, and population-wise, we're very sparse. And that creates challenges in terms of space, distance, and transportation. The Northern Health Region also cares for the most marginalized population in Manitoba and possibly Canada. And in addition to the burden of illness, we of course have difficulty recruiting enough nursing staff, as do most areas in Canada, to provide care for those patients. But today we are going to talk about retention. Before I get started on the Nursing Practice Council and how it is in its present state, I'd like to give a little bit of history and background as to how this came to be. So during 1994, 12 children died while undergoing or shortly after having undergone cardiac surgery at the Children's Hospital in Winnipeg. Throughout 1994, concerns about the deaths of each of these children and about the condition of the children from other surgeries had been expressed to people in authority at the hospital by members of the nursing staff. In May 1994, following the death of the 5th of the 12th children, the members of the section of pediatric cardiac anesthesia unanimously agreed to refuse to participate in any further pediatric open heart cases until a review had been undertaken. And I want to emphasize that the nurses brought their concerns forward regarding these situations, and that it wasn't until the anesthetists refused to continue providing services that a review committee was appointed, and the program continued to provide service for low-risk cases during that review period. Cases that could not wait the outcome of the review were transferred out of province. And during this period, concerns were expressed by the PICU nurses and the NICU nurses over the types of procedures that were to be carried out in the intensive care units, and they were not addressed. It appears that the concerns of the operating room nurses over the nature of the deaths that occurred and with the mortality rate were interpreted as the nurses' inability to cope with the unfortunate, unavoidable death of a child. There was an implication that the nurses lacked a vision of the larger picture. When the hospital was reorganized in the summer of 1994, the position of Vice President Nursing was eliminated. Finally, the evidence suggested that despite its stated intent, the hospital reorganization of 1994 implicitly devalued nurses, since it appears to have been driven by a concern to cut costs primarily by reducing nursing staff. Throughout 1994, the nurses made proper and appropriate use of existing channels to voice their concerns. But for a variety of reasons, some personal and some institutional, their concerns were not attended to. Indeed, the reception they were given led nurses to silence themselves. It also left them frustrated, distraught, and many paid a heavy emotional price. The recommendation from Judge Murray Sinclair was as follows. It is necessary to put in place structures that ensure all staff can make their concerns known without fear of reprisal. It's also important to ensure that the structure of the HSC be adjusted to ensure that the position of nursing does not continue to be a subservient one. It was advised that the HSC restructure its nursing council to allow nurses to select its membership and give responsibility for nursing issues within the hospital. The nursing council should have representation on the hospital's governing body. So that's a little bit of the history and background and how the Nursing Practice Council came to be. Next slide, please. So currently with the Nursing Practice Council, as we operationalize it in the Northern Health Region, we started it in 2015. And as we said, you know, the Nursing Practice Council, a number of hospitals in Winnipeg do have a Nursing Practice Council, and there are some throughout Manitoba as well. In the North, the Nursing Practice Council started up in 2015, so it's quite a ways away from 1994. And when I first came to the North in 2018, the structure of it was that it was information sharing, and that what would happen is the chief nursing officer would basically provide information about what was happening in the rest of the province, and then, you know, the nurses could ask questions, and that's how it went. So over the years, the Nursing Practice Council in the North has really morphed, and the nurses are very engaged and very involved. I think we have the most enthusiastic nursing staff there is. And they have expressed that being able to be part of this Nursing Practice Council has allowed them to work to their full scope of practice, and to feel like they actually inform their practice and the way they do their work. So for example, when a new practice is being proposed by, say, provincial leadership, it's brought here for discussion and for feedback. If they find that there's a practice that's no longer proven effective, or it's identified as flawed, or it's out of date, again, the Nursing Practice Council discusses it and analyzes what they can do about it. This often leads to working groups being formed that develop strategies and draft policies and procedures. So in the morning, we do the information sharing, and then in the afternoon, they break off and work in working groups. And they've done just a remarkable job in addressing practice issues as they come up, and then addressing them in the afternoon, because we often say, if you're going to come to Nursing Practice Council with an issue, you should come with two solutions. Next slide, please. So sorry about that. I'm just going to go to my next slide. Any patient safety experiences that are brought forward to the Northern Health Region Patient Experience Department, or to any of the leadership, is or relevant complaints are often brought to the Nursing Practice Council for their discussion and resolution. We're obviously the largest part of the working population in the Northern Health Region, and so we really work to inform our practice. The morning of the meetings, as I said, is information sharing, and then at the end of each meeting, they have their 5 takeaways. And again, this is a practice that is then shared. The 5 takeaways are shared with the nursing practice committees on each inpatient unit, and the emergency departments as well, and our public health nurses, our mental health units. They all have nursing practice committees that roll up to the Nursing Practice Council. Any issues, any policies or procedures that are changed or adjusted are brought to Nursing Leadership Council for final approval. If the changes that they are seeking involve other disciplines, we have a clinical advisory council that the Nursing Practice Council brings their changes to for comment and for approval. And then again, anything that involves sort of a monetary aspect is brought to the Executive Leadership Council. So you can see back from 1994, where there wasn't a very good flow of communication up to the executive level to make very important changes. There was no mechanism for nurses to do that back then. We have a very clear flow of how nursing practice issues are brought to senior leadership. So most recently, the Nursing Practice Council has worked on standardizing documentation across the region. They have developed a charge nurse manual that is an invaluable resource for nurses who take the charge nurse role during weekends and off shifts. And the newest thing that they have done is they have added a standing agenda item, which is to address anti-Indigenous systemic racism. And so at every meeting, they have a conversation, and they will either pull in complaints that have been heard by the patient experience folks or critical incidents. And we have a patient safety person that comes and discusses all of these things with a lens on anti-Indigenous racism and how we as a nursing group are going to solve these issues. And so that's just an example of what happens with the agenda and how this budding leadership, their engagement, their enthusiasm, and their passion for nursing has really turned this Nursing Practice Council into something that they can be very, very proud of. And we have a number of nurses that request being on the Nursing Practice Council. And I'm seeing the question about how do we measure this? And I actually explained to Randy and Jennifer, we didn't have an analysis where we looked at the retention. It is purely, quite honestly, at this point, anecdotal, but we know that the Nursing Practice Council members don't turn over, that they recruit people to the Nursing Practice Council, and we have got a very enthusiastic group. And I'm getting the time up, and next slide, please.
Yeah, thanks, Shannon. I was just going to say, I want to make sure we have room for our other speakers.
You bet. And I really, that was the end of my presentation, that we have the engagement of nurses that rolls up to the leadership. They have a key role, obviously, in their practice and in addressing and developing practice. Thank you.
Fantastic. Thanks so much, Shannon. I suspect there will be some more questions and comments coming into the chat, or maybe just even on audio once all the speakers are done and we switch over to the discussion session of the session today. So up next is another prominent Manitoban, Melanie McKinnon, who's the Executive Director of Ungomazwin Health Services at the University of Manitoba. Melanie's presenting on the physician assistant model that she and her team have helped to advance in partnership with others in Manitoba. Melanie, the virtual floor is over to you.
Thank you, Randy. Good afternoon. Good morning, everyone. It is a pleasure to be here today. And thank you, Shannon, for your presentation. It is an honor to work closely and collaboratively with the Northern Region Health Authority. So I'd like to present some work that we've been doing just in the last recent years around the creation of physician assistant full-time equivalents or positions in northern remote communities, specifically the nursing station environment that are often run by the First Nation Inuit Health Branch or Indigenous Services Canada. Next slide, please. I should also start that I am First Nation. I'm Cree from espoused to Cree Nation. I also grew up in Woboden, Manitoba, and that beautiful background behind me is just 15 minutes from home. Still very much connected to my family and my relatives who are still within the region, but also throughout Manitoba. A little bit about Ungomazwin Health Services. It was established by Dr. Jack Hildes in 1969. Prior to the pandemic, we were able to celebrate our 50th anniversary. And I kind of joke sometimes that was probably the last time that I've been in high heels and have been in slippers or moccasins working from home for quite some time. It'll be interesting to see if I can still do that these days. Really fortunate to have now been with the organization, which again was formerly called the Northern Medical Unit, for a dozen years. And what I'd like to present today is the newer scope of practice that we've recently introduced into a longer standing organization that is principally made up of physicians and physician specialists that we deploy into 26 out of 63 First Nation communities throughout Manitoba. And we also have some nurse specialists, specifically dialysis nurses, retinal screening nurses, and foot care nurses into Manitoba communities as well. In relation to our services in Nunavut, specifically the Kvaluk region, we provide physician specialists and med rehab specialists, both within the healthcare system, as well as the Department of Education. And the PA program that I'll be sharing is specific to Manitoba. Next slide, please. We had an opportunity in the beginning of the pandemic to introduce a new scope of practice as we were all throughout the country and throughout the world trying to gear up to ensure that we had clinical services in all of our communities, but especially those that were the most vulnerable in their geographical isolation, but also in terms of their health status and healthcare needs. We currently have 7 physician assistants working in 7 or 8 communities at this time. We are looking at an expansion program and plan and currently under negotiations with both levels of government. We wanted to introduce the scope of practice as physician extenders, as we all know that they're not independent practitioners, but also to be able to introduce a new discipline in working on the teams in the nursing stations. Over the last 3 years, we were able to secure an annual budget of about 2.2 million, specifically from Indigenous Services Canada. It is under discussion as it is an insured service. This is now we're trying to transition from a pilot or proof of concept into a program. And as all of my colleagues on the call can appreciate, that does take some time and effort in working with multiple jurisdictions, specifically to provide services in First Nation communities. What we've seen in the last 3 years that the PAs have improved access to care for remote First Nation communities, and to date have provided an additional 10,000 hours of service. And they're certainly contributing to quality and safety through culturally safe care and team-based care. Next slide, please. We have not yet done a formal evaluation that is currently being framed, but we do know a few early outcomes with respect to cost efficiencies and system improvements. But what we've been able to demonstrate as of the last couple of years is that there is in fact improved retention. There's improved workflow between the nurses and the physicians. We're able to take on higher volume of care within the nursing station environment. Certainly there's improved share care. And I think what's really important is in that nursing station environment, for those that aren't familiar, the nurses and physicians are responsible for public health, primary care, acute care, and urgent and emergent care, and transition to higher acuity centers if that is indeed the case. So it's a broad continuum of service and care. What we found with the introduction of the PAs is that they could focus on some of the chronic disease management, and so less of the acute and kind of being pulled out of clinic and managing an emergency, for example. So again, a really specific designated function. And they've certainly provided incredible and critical surge capacity during times of shortage, both throughout the pandemic, but as well as the Christmas and the summer holidays. And we hear from our nursing colleagues that sharing the clinical workload has alleviated significant pressures off physicians and nurses, and could not imagine now working without PAs as that scope of practice has been recently introduced. Next slide, please. So there are a number of key critical success factors that have allowed us to onboard and retain some of the PAs that we have, and certainly have a few that are also wanting to work with Algonquin. And so some of those include a flexible work schedule or opportunities with variable FTEs, anywhere from a 0.25 to a full-time equivalent. Part-time FTEs allow the physician assistant to work in other clinical environments throughout the province and other SDOs and maintain their clinical competencies, but also allows them to have a part-time service commitment into our communities. There's been significant physician advocacy and mentorship between our physicians and the PAs. I would be remiss to exclude the degree of mentorship and orientation that's required during the onboarding process. And it's upwards of 4 to 6 months of some pretty intense and concerted leadership and mentorship. But I also want to acknowledge the work that we've done with the College of Physicians and Surgeons in Manitoba to not only formalize and streamline the onboarding process and documentation and evaluation and review process that's required under their clinical scope of practice, but that we in Manitoba, through the College of Physicians and Surgeons, have also created a new classification of a PA with an expanded scope of practice that is able to function in their PA role under remote supervision, which is new, certainly to this practice environment in Manitoba. I'm happy to answer questions about that if there is in fact any. But we also spend significant amount of time matching the correct PA with the right physician in the right community and practice setting. So there's a lot of thought and effort gone into the assignments and into the deployment. Next slide, please. I think this might be one of the last ones. And so we'll continue as far as our next steps go to solicit our sustainable funding base and look at program expansion. We want to transition from a project to a program with clear structures in place. We anticipate over the 5 years in our work with our federal and provincial partners that we can expand the PA scope of practice to roll into all of our clinical sites, which would be almost 29 FTEs. And we're looking at opportunities for multidisciplinary microcredentialing, Indigenous health fellowship training programs, and working with other academic institutions and service delivery organizations to be able to be practice ready. And I'm going to say that again, to be practice ready to work in an Indigenous, complex healthcare environment where autonomy and clinical and cultural competencies are absolutely required. We don't necessarily graduate ready to practice in this type of environment. And we'll continue to work on our evaluation plan and needs assessments as required to ensure our sustainability and success. Next slide, please. So thank you very much for the opportunity to Healthcare Excellence Canada to present, and look forward to my colleagues' presentations and any questions. Thank you.
Awesome. Thank you so much, Melanie, for another great presentation. We're moving now from Manitoba north to Nunavut. So our next presenter is Lisa Little, who will be sharing work that she and others in Nunavut have been leading to create a roadmap to strengthen the Nunavut nursing workforce. Over to you, Lisa.
Thanks very much, Randy, and to Jennifer. I'm a consultant who's been working with the government of Nunavut in the Department of Health to develop a roadmap to strengthen the health workforce, and in particular, the nursing workforce. Next slide, please. So a little bit about Nunavut and the context. There's about 38,000 people there living in 25 communities, which are fly-in communities only. Each one of them has a community health center, and there's one hospital in Iqaluit, which is a secondary hospital. About 84% of the population is Inuit, and nurses form the largest part of that workforce. Nunavut has all categories of nurses, so registered nurses, licensed practical nurses, registered psychiatric nurses, and nurse practitioners working in Nunavut. And they're predominantly providing care through an expanded scope of practice for their community health nurses. The physicians are typically in most communities a fly-in service only on a rotational basis, except they're obviously in Iqaluit all the time in some larger communities. So recruiting and retaining nurses is key for Nunavut, given the tremendous amount of services that they provide in terms of direct care. And Nunavut has struggled, as you can imagine, for its remoteness and some of the harsh winters, et cetera, and weather that they have. in getting people there and keeping people there, often with a 40 to 50% vacancy rate. So retention and recruitment is a key piece. And as we all know, you can recruit as much as you want, but if you don't retain, you're not getting any further ahead. So retention was a really key piece of this puzzle. Next slide, please. So the roadmap to strengthen the Nunavut nurse work consulted through focus groups with nurses across the territory. I couldn't fly to every community to do that, so some were done in person and some were done virtually. And I made a purposeful effort to segment various portions of the nursing workforce. So by occupational group, and then by community, and then by leadership team. Also by, I engaged with the nursing students who are at the college there, who typically come to work then for the Nunavut government, as well as by the type of environment that they're in, whether they're in mental health or they work in other areas. So trying to get a real different range of input through that process. To accompany that, I did a lit review, a peer and a Grey Literature lit review that was 10 years back, and really focused on rural, remote, and northern nursing and what that looked like from the research perspective. Together with the results of the focus groups and the peer review literature review and Grey Literature review, I did a thematic analysis then and pulled out the themes that arose. I then shared these back with the nurses from across the territory, every one of them that works for the Nunavut government, in an online survey. And at the time, there were about 160 full-time nurses working for the government, and I had a response of over 100 Nunavut nurses, which was fantastic, a little over 60% response. And they were all very supportive of the themes that had emerged and the solutions that they had identified that would form some of the strategic directions in each of those thematic areas. This draft was advisory committee, similar to what you described earlier as your council in Manitoba and the Northern Health Authority. And it was also reviewed by the Health Human Resources staff to see if there was any issues or any other inputs they would like to have. The final version was then sent back out to nurses again to get their support, and again received very positive support from a very large number of them. So the roadmap itself you can find on the Government of Nunavut website under the Department of Health reports. It includes specific goals, strategies, and actions. And to accompany that roadmap, I developed an evaluation framework using process, structural, and outcome indicators mapped to the strategic directions of the Government of Nunavut Department of Health and their quality improvement plan. And so we monitor indicators at various times of the year. You know, it includes the indicators, their definition, how often, how we're measuring them, what is the calculation, where are we getting this data from, etc. And that's for each of the 5 pillars of the roadmap that you'll see shortly. Next slide, please. So these are the 5 pillars of the roadmap itself. And you can see that retention is a key part, really comprising pillar 3, 4, and 5 in that aspect. And we took this roadmap and we worked through with the Nursing Leadership Advisory Committee to actually develop a year 1 work plan. So we looked at what are the priority areas, what projects might be already underway that would fall under the roadmap, and which ones they would like to start new that were really priority, and what would that look like as a project. And so we developed a very detailed year 1 work plan. Next slide, please. As I mentioned, the evaluation framework for the roadmap has, probably 100 indicators in it. And one of the things I did at the beginning as well was a feasibility study to look at, is the data that's available for these indicators in an information system? Is it manual? Is it quality data? How much work is it going to take to pull out this data out of systems, or is it already in an existing query or report? And that helped us look at which ones we could initiate and start to report on immediately, or which ones still need a little bit of work to allow us to evaluate over time. So we created a dashboard based on those indicators with some visuals that's presented quarterly back to the Nunavut Nursing Leadership Advisory Committee, as this group has the responsibility for the oversight of its implementation and monitoring and evaluation of the roadmap's progress over the 5 years from 2021 to 2026. I've shared with you some of the outcome retention indicators that are included in the evaluation framework, but we have many more structural and process retention indicators as well, looking at everything from job satisfaction to incidents of workplace violence, to the availability of fitness equipment, which is a huge retention factor for them and linked to their job satisfaction, their intention to leave, all kinds of ones that we examine. Again, some are monthly, some are quarterly, some are yearly, depending on the nature of the indicator. Next slide, please. So, year to develop the roadmap itself. Of course, we got caught up in COVID, and that took a little bit in the delay of releasing it, actually, because it's translated into 3 official languages. But looking back at the key success factors, the leadership of the Assistant Deputy Minister of Health Operations, which just prepared herself, really championing this made a big difference. Really that, setting the culture of this is what we're going to do. We want to help nurses. We want to improve recruitment retention, and we want your input. We want the nurses involved in this. We want you to drive and direct the shape of this roadmap. And that's the second part, the high-level engagement from nurses who participated through focus groups or interviews on the phone or through the online surveys that we did throughout the process, and the members of the Nursing Leadership Advisory Committee as well. That really gave them a shared decision-making. So we really made sure that as we went back to them and changed things, that they were okay with things, or we refined things in the roadmap based on their input around the pillars of priorities. The work plan under specific projects that would meet the needs under the roadmap of various initiatives or priorities. And then, of course, it was evidence-informed, where we looked at the literature to learn from other remote areas of Canada and the world. Of course, Australia and some of the northern countries certainly have some good information that we were able to use. And as I reflected on this again over the last few days, that I think is important is that they've committed the resources to actually shepherding this roadmap, making sure the data gets pulled, making sure the information gets presented to NLAC. I happen to be the person that does that, but it doesn't have to be me, obviously. But really making sure that the team is supportive, because they have such high vacancy rates. There's not a lot of extra staff to be able to take on some of these big elements. So I provide that support to the NLAC and work in making sure, just kind of directing and shepherding and doing some of that legwork for them to get it to a point where they can make decisions about things and monitor and see what results are working when we try initiatives, or that's not working and we need to pivot and change direction on elements. Last slide, please. So the next steps are, we're absolutely in the process of publishing a year 1 progress report of the roadmap. It's currently just finishing up translation, so it should be out on the website as well under the Government of Nunavut shortly. We've prepared a year 2 work plan, and we've started work on several new projects that are coming forward under year 2 of the work plan. And then, of course, because of the data challenges, as always, in information systems, we continue to work on enhancing the data collection on our evaluation indicators so that they're more automatically generated, and we're pulling less manual data over time. But so far, it's working, fairly well. Next slide, please. And with that, I'd like to say thank you and thank the Government of Nunavut for the opportunity to work with them.
Great presentation, Lisa. Congratulations on the work. I was so surprised and impressed when you said you had engaged like 100 of those 160 nurses that you sent the survey to. That must have been very gratifying. Probably we'll have some comments and questions about that at the end. But at this point, I'm happy to turn it over to our final presenter for the day, which is also another presentation from Nunavut, as it turns out. So we have now Jasmine Pawa, who's a public health physician and a consultant with the Nunavut Department of Health, who'll be presenting the Basic Radiology Technician Program. Jasmine, the floor is yours.
Thanks so much. Thank you for the opportunity to present here, and to all of you attending online right now. I acknowledge very much that I'm here on behalf of a team who developed, implemented, attended, or otherwise contributed to the success of all of this work. As mentioned, I'm a physician, a specialist in public health and preventive medicine. I do contract and consulting work for public sector organizations at local provincial, territorial, and national levels, and do a fair bit with our National Specialty Society as well. And in recent years, a significant amount of my work has been with Nunavut, part of Inuit Nanangat. And I think the importance of thinking about our history as a country and our connection to the land is crucial, and also thinking about how that links with our work, hiring, teaching, giving presentations like these, and how the lens I bring working for public sector organizations and existing institutions and with my background also impact my perspective. I find health policy and governance and decision-making fascinating, including some of the power structures and how we engage with community and how we deliver health services, and have a really good experience for members of the public and providers. Next slide. So I'm here to talk a little bit about the basic radiological technician or BRT program today, but I'm hoping to keep it in the larger context of our models of care, how we share work and tasks, and working as teams. I'm hoping it might prompt some thoughts for you about your own context and what's working well or what opportunities there might be. And also really appreciate the opportunity to learn from different parts of our country, between provinces and territories, urban from rural and remote, and the reverse, and to do that through quick touch points. Next slide. So the program, sorry, one slide back, apologies. The program has been in place about 5 years now. And as mentioned, there's a richness and strength in the territory and Inuit knowledge. At the same time, lots of challenges with infrastructure, recruitment for service delivery, and other pieces, and no roads in or out of the territory or between communities. So patients have to fly out for significant amounts of care. So challenges have been identified with inconsistent X-ray services, poor qualities of the images, limited training and availability of people to perform X-rays, and it was often adding to the nursing workload. So this program trained individuals from the community, often individuals who were in clerk interpreter or custodial roles, to safely and effectively do the X-rays. It built off a previous program about 20 years ago that had been doing this, but sort of dropped off. And this training was done with a mix of in-person and community, as well as remote support in between over the course of 2 years with certification. And given the small population and the breadth of the communities it covers, the numbers trained so far have had quite an impact while being small in absolute numbers. Next slide. And as I know many of us talk about, I've really appreciated coming back to the quadruple aim when we consider health services and finding ways to evaluate our health outcomes, so including equity, cost, patient, provider experiences. I really believe that the patient or public and provider experiences are crucial to retention. It's harder to measure quantitatively, or we rely on qualitative feedback, and we can work out how to best consider both of those. Qualitatively, there's been very positive feedback about the program so far, that this type of task sharing was very positive, more manageable workloads across the team, that community members had an even greater role in providing health services. And we believed it to have prevented out of territory travel for repeat diagnostic tests, although that's more difficult to demonstrate. The timeliness and image quality in terms of patient positioning, image processing, and quality was assessed by an evaluation done by radiologists in Ontario and was found to also have improved and been better. Next slide. So we feel that many of the success factors relate to the training and work closer to home, that participants of the program know their communities really well, and this can help us to work towards more care delivered in an up-to-date. We've heard sometimes as programs like these come in that there might be concerns about safety or quality or legislative regulatory frameworks. And I was excited to present today to talk about how we can absolutely do this kind of work if there's good training, support, follow-up, and as part of a team. In Nunavut, we were fortunate that the Safety Act, there was a provision for a qualified operator to operate radiation emission devices. And so this program was the qualification that let us meet those requirements under the Act. And from a professional practice perspective, it was designed by the Ontario Association of Medical Radiation Sciences, ORMS, to align with the medical radiation technologist competency profile that's published by their Canadian Association. So those competencies were very carefully thought through. And then another important consideration is that we talk about the opportunities for further training work and support. Maybe somebody might want to consider nursing training or laboratory technician, epidemiology, others, and that we have opportunities to connect that if there's paths people want to take with their professional careers. So next slide. So we're continuing to work to expand this to continue it as it is, and also work potentially to expand it. We still have some work to sort out to ensure that pay aligns really well with the work completed. And we have some other related projects that take very similar principles to the work. Next slide. And thank you very much again for the opportunity to be here and share a few thoughts. And I share acknowledgements again to a large team a part of this. And please don't hesitate to reach out at all if you have any questions, comments, or thoughts in any way. I'll turn it back to you, Randy.
Fantastic presentation, Jasmine. And I think we're going to be able to now open up the floor. I see that earlier on in the chat, there were a number of questions directed at Melanie, and that she has been very dutifully working on her keyboard and answering those questions. So I think the ones that have come in so far have all been addressed. We've got about 3 or 3.5 minutes, so I would welcome anybody else who has a question or even just a comment to do so in the chat, or you can unmute your microphone and ask your question just orally. I just need to comment though on that last presentation, Jasmine. It seems like it's the beautiful example of bringing new people into the mix of the healthcare providers that we've got. Because I mean, I know one of the challenges of lots of things of upskilling people and expanding scope of practice still leans on the existing people that we've got. I know in Manitoba, there's been a big emphasis on surgical and diagnostic imaging recovery after the pandemic. But it's almost like the priority in the funds and the emphasis given to that program is taking people away from other jobs and positions. So it looked like that BRT program was adding net new capabilities and people to the system. Do I have that right?
Yeah, so I think like anything, it's not without challenges. There's lots of work for our clerk interpreters, custodial staff, others who are part of the system. But at the same time, I think at least one person had worked with the post office and was trained to do this. So it definitely does help us think about the mix of work and where we can kind of save time for different pieces and also have people feel very, very much in the team and working to full scope. So yeah, I think that's fair. Just thinking a lot about the specific pieces of the puzzle we all bring.
Yeah, it's a big part of the government and Nunavut's commitment to try to get more Inuit involved in staffing and in service and care provision across the government and across the territory. Okay, well, I'm going to give one more minute call, sorry, last minute of play in this period. Maybe I should speak Canadian. I'm going to turn the floor over to Jennifer Major to talk about a couple of HEC initiatives that I know many of you will be interested in. There are new things that are just coming down the pipe. So going once, going twice. Okay, I'm going to call it for now and I'll hand the floor to Jennifer. If you have a question though, still please feel free to put it into the chat and we can get back to you or get it to the person responsible at this point. Where you go, Jen.
All right, thanks, Randy, and thanks so much for the presentations. They were so great to hear from all of you and really shedding the light on the excellent things that are happening in the northern rural remote communities in Canada. So next, I'm going to share information about 2 new upcoming Healthcare Excellence Canada programs that may be of interest. And actually, thanks to Melanie McKinnon, who's a member of our advisory committee who's helped inform this program. So both programs I'll talk about recognize the strengths of local leaderships and communities bring to support healthcare and aim to shed light on those strengths and provide tailored supports to respond to the needs of local communities and providers. So the information about the first program is there on the slide. It aims to strengthen and improve access to safe, including culturally safe, team-based primary care in northern rural remote communities. Example benefits include seed funding up to $50,000 per team, virtual and in-person networking, coaching, and learning activities and events, and support to adopt or strengthen a promising practice that meets the needs of communities and providers and improves access to team-based primary care. Participating teams will be supported to measure and evaluate the impact of a promising practice on patient and provider experience, reduction in medical transfers and avoidable ED visits, and in other ways based on the impacts that participating teams want to achieve. So who should apply for this program? Groups involved in delivering team-based primary care in northern rural remote communities. We encourage multiple organizations to apply together, so their efforts to adapt or strengthen a promising practice can reach more people. So an applicant could include, for example, a regional or Indigenous health authority in partnership with several primary care clinics or nursing stations, or an Indigenous, provincial, or territorial government in partnership with community-based organizations involved in delivering primary care, who all want to work together to strengthen or adapt a practice that improves access to team-based primary care. How and when can you apply? Applications will be open July 11th and will remain open until September 25th. HEC will schedule calls with interested applicants to help assess eligibility and support the application process. So you can see the email there on the slide for who you can email, and I think Megan will pop that into the chat. And then together with an advisory committee, we will review and select teams to join the program in October, and activities and benefits will start in November and run until September of 2024. So definitely reach out if you want more information about that program. So on the next slide, there's information about a second program. So this one is called the Health Workforce Innovation Challenge. So a bit of background, many dedicated people, teams, and organizations are advancing innovative approaches that address health workforce issues head on, as we've heard today in the webinar. So to support and help scale those important efforts, HEC is launching the Health Workforce Innovation Challenge. So what is this challenge? If you or your colleagues are wanting to launch a new initiative that focuses on retention and support strategies for your current health workforce, then this program may be of interest to you. It's an outcomes-based program that features opportunities for monetary awards over 12 months and recognizes and rewards the successes of teams moving the dial on improving the retention and support of their current workforce. Registration opens June 27th and will remain open for incoming teams until April 30th of next year. Teams can participate as much or as little as you want, but the sooner that teams join, the more award opportunities you'll have. So on the next slide, you'll just see some example benefits of joining the challenge. So you'll have, next slide, please, I think. Access to monetary awards. So the teams could potentially be awarded up to $112,000 if you can maximize all the program offerings. You'll have an opportunity to connect with a broader community of innovators and people from across Canada who may be facing the same challenges or have really good solutions for what you may need. Access to coaching supports and a host of evidence-informed tools to support initiatives, including bi-monthly webinars. There's also going to be measurement and data collection support to help track progress and report on outcomes along the way. So for more information, you'll be able to find that on Healthcare Excellence Canada's website starting on June 19th, including links to the details of all the award opportunities. And there's some information in the chat there as well. HEC will be hosting 2 open question and answer sessions on June 28th and July 19th. So stay tuned for those, and the link to register will be included on the HEC website also starting on June 19th. But if you have any questions in the meantime, please feel free to reach out to the email address that's on the slide there at challenge. That'll get you to an HEC staff person who will get back in touch. So now I think with just 5 minutes left till people can go and continue with your workday or maybe go for a walk, we'll just do the closing polls. So this is just a short survey. Your feedback is invaluable for us for future session design. So we ask you just take a moment to provide us with some feedback on today's questions. So you see the polling questions have popped up there. So the questions are, the first question is, what is your gender? Gender refers to a gender that a person internally feels or the gender the person publicly expresses. The options are man, woman, gender diverse, or prefer not to disclose. The second question, did your knowledge about promising practices that support retention of the healthcare workforce in northern, rural, and remote communities improve as a result of participating in today's webinar? The third question, do you feel the webinar provided useful information? Yes or no? And then please be sure to hit submit to share your responses with us. And we really appreciate your time in doing that. It's super helpful for us as we plan future events. So I'll just give that a moment. And then while people are cluing up on the polling, just want to say a huge thank you to Randy at ChiHi as my co-host, and of course, Shannon, Melanie, Lisa, and Jasmine for your excellent presentations. We really hope that the participants on the call today found your presentations encouraging and enjoyable and was helpful for the work and what you do. And thanks to everyone on the line today for taking time out of your busy schedules to join us. So if you do have questions or comments following today's event, please contact us using the email, or you can contact me using the email address that's on the screen. So this concludes today's event. Have a great day, everyone, and thanks again for joining.
Great help, Heck. Thank you, everybody on the tech side.
Thank you very much. Take care.
Bye, everybody.